Welcome back to Psychiatry Boot Camp. I am over the moon excited to be bringing you this episode. We are discussing decisional capacity again, but actually at this time we're taking a critical look at how decisional capacity is discussed. I first encountered our guest today, Dr. Omar Mirza, at a consultation liaison psychiatry conference in Austin, Texas. He was a speaker during a workshop looking at alternative models for assessing decisional capacity, and the session was an absolutely packed house. I almost mistook it for a Taylor Swift concert inside the hotel, but it turns out just an academic presentation by Dr. Mirza. Truly standing room only, bunch of people spilling out the doors, and I was absolutely enraptured by Dr. Mirza's ideas, and he delivered them both with a fiery passion that you don't often see at academic conferences and an appropriate bit of humor, which was very refreshing. So when I saw your presentation in San Antonio, I was enraptured by it, and I found it really intriguing, but I also found it deeply disturbing and really uncomfortable to sit through. Like, it was my favorite presentation at the conference, and I think my favorite, I'll say the most impactful educational workshop I've ever been to at a conference, but also not something that I really particularly enjoyed having to think about. And you mentioned again here that you feel like the Applebaum-Grisso criteria sometimes harms the patients that we're trying to serve. What are your specific concerns there?
Yeah, no, I appreciate it. I think if I speak to the intention of the talk, it was really designed to kind of create discomfort. I guess the analogy might be, when you go to like a trainer, if you walk out of there and you don't feel a little sore, you didn't really do anything. And so intellectually, I try to craft talks that hurt a little bit, because then you feel like, oh, there was something that happened. There's a way to kind of punctuate the experience. And I think in some ways, maybe I was a little bit intentionally provocative, but not in any way that sort of, I think, stretched the truth. I wanted people to feel that so that they could really reflect. So coming back to the question about harms, I think the issue really, for me, is that the model, while intended to really promote autonomy, has now become sort of the tool to suppress autonomy. It's really done the exact opposite. And I'll speak to that a little bit by jumping into the history, if that's okay, because I think that's a great way for us to contextualize it. So going back to sort of pre-autonomy days, to the sort of, I'd say, paternalistic ancestry of medicine, we've always really kind of consolidated power in the hands of the physician, with the sense that the physician has the superior knowledge, the ability to treat, and therefore the authority to make decisions on behalf of the patient. Coupled with that is the sort of trust that the physician is going to do that with beneficence in mind, right? Before these terms really were developed, that the idea that the physician is going to take care of it. In reality, we found that that wasn't always true, and the law had to step in to protect that. And sort of the first evidence we have of that was when we had Schloendorff versus New York Hospital, where Mary Schloendorff came into the hospital, abdominal pain, they suggested surgery for leiomyoma. She said, wait, no, I don't want that. They sort of convinced her under duress to say, hey, let's do this examination under ether and let's just try that. Of course, as we talked about in the presentation and as we know from history, that wasn't the end of it. They went forward and went ahead and had a surgery. And she ended up having to deal with consequences of that weren't even intended by the physician. She ended up getting gangrene as a consequence of the recovery. And so she ended up, with harm that wasn't really intended. But the reason that is important is because that really took that case to the courts, where we have Judge Cardoza say that anybody of sound mind and adult age has a right to determine what's done with their body. And that doing so without that consent of an individual is basically, a violation of their legal rights. And so legally, that's the first time we kind of see that established. And that's sort of where we get this idea of consent being sort of so paramount. Though at that time, capacity really wasn't explicitly articulated. It was implied with this idea of sound mind and adult age, but it wasn't sort of as a word really articulated. You flash forward really to, I think, really the Nuremberg trials, where we all kind of recognize that the Nazi doctors were put on trial globally on a global stage for all the harms that they sort of inflicted on unwilling and unconsenting patients. And so they reaffirmed this idea that we must have consent. And in order for consent to be valid, there had to be certain subcomponents. And that's where you started to see things like it has to be voluntary, which seems intuitive, but they had to articulate it has to be voluntary, which made sense at that time, given that, a lot of the folks that were being conscripted into care were in concentration camps. So there was no voluntariness. Two, that there has to be some form of disclosure, right? Which was the articulation of the risks and the benefits. And that the person had to have legal capacity. And they sort of said legal capacity at that time. They didn't really articulate the four models, a sort of abilities model as Applebaum and Grisso had done, but they had sort of foreshadowed this idea that there's got to be some legal capacity. And I think at that point, it wasn't really this idea of the capacity to make decisions as we think about it today. What I think really they were concerned about at the time is that, hey, there is clearly going to be these sort of outliers that don't have the ability to make decisions for themselves. And that I think the one that comes most clearly to mind is children. So they weren't going to create this dictate that everybody can decide what's done with their body, because obviously there's certain people in society we decide that can't necessarily do that. And so that's why they emphasize that sort of legal capacity. You bring that back to the States in the 50s, and I sort of talked about this at the talk as well. Opposite coasts in California, you got Martin Salgo, who comes into Stanford, gets an aortography, but isn't told that the consequences of that could be paralysis, ends up getting paralyzed, obviously sues as a good American would. And the court says, okay, in addition to consent, which is what we saw in New York, you really have a duty to disclose. And that duty to disclose is critically important to consent. And that's where we get this idea of informed consent or intelligent consent. And so what you're seeing and what you're hearing in this sort of narrative is that the entire focus has always been about making sure that the consent process is about ensuring that the patient is in control of their decisions and that patient is armed with information, disclosure, to make those decisions. Capacity was not so much the focus of informed consent at that time. And what the Applebaum and Grisso model has done is that it has, through its efforts to standardize the part of consent, which is the legal capacity, in a model that people can apply in a standard form, shifted the focus away from voluntariness, away from disclosure, to this idea of capacity.
You start to lose the forest for the trees, right? The idea is all three of these things working together make consent happen. They render someone able to consent and giving consent. But when you focus on just one of those criteria, it might be maybe not a zero-sum game, but you might have to rob Peter to pay Paul a little bit.
Absolutely. Absolutely. And the courts warned about this early on. Canterbury versus Spence kind of said, be careful, because the implication of informed consent is that comprehension is the key component, rather than really informed is the responsibility of the physician to disclose. Like, that's the whole point of informed consent. The responsibility is on the physician to disclose, right? You can't be giving valid consent if we haven't empowered you with information. And that was sort of the real emphasis of early consent, to say consent's not just saying I agree or not. It's that we provide you with the power via the information, expertise, and knowledge that we have as physicians so that you can make those decisions, and not that we need to arbitrate your comprehension. Comprehension is really kind of again, puts the focus on the patient and not the focus on the physician providing the information, which is what really the courts were looking for.
So you need both of these things. You need the informing part, and you need the patient's ability to, I'm going to say, you do need the patient's cognitive ability to understand, appreciate, etc. But your concern is that, at least in our psychiatry training, we're focusing pretty solely on is the patient able to demonstrate these four criteria? And by doing that, what we're forgetting is, have we informed the patient of everything that could possibly happen? And have we really thought about what this patient would want longitudinally based on their values, despite their current cognitive condition?
Yeah. Well, it depends. How radical do you want to go on this podcast?
Let's go. I was I was going to give an example of radicalism, but let's just say very radical.
Okay.
Let's do it. Let's fucking do it.
Let's do it. So I'll say this then. We don't need to focus on the cognitive abilities. There's an interesting article that I sort of just stumbled upon, and I'm forgetting the author, but they talked about, when we describe capacity, we talk about it in sort of like multiple domains, but really there's several different types of capacity. There's a capacity which maybe is more philosophical about, is there free will? Is there an ability to make decisions freely, without coercion or external influence? And that's one form of capacity, which I think we medicalize a little bit. And then there's the other form of capacity, which is, do I have the legal right or authority to make my decisions free from intrusion of others? And those things get blended together. And I think what capacity as a subsection of informed consent is really intended to protect is that sort of legal right to make your decisions without other people intruding. And that's a sort of legal state. And what I mean by that is, like, I think almost universally, though you could argue ethically, maybe it's not so universal, except that children are legally deprived of the ability to make their own decisions. We collectively have agreed that we're going to say, you're the exception to this rule. And so I think when we talk about capacity, legal capacity, we're talking about who have we in society agreed can make the decisions and who have we decided cannot. What's happened through these models that medicalize capacity is that we started to bring in cognition and the idea of assessing cognition to make decisions. And that's where then you borrow concepts which are like testimony capacity or legal capacity in the sort of context of forensics, which I think is morally and ethically slightly different, right? The idea that you participate in a court case and testify, and those things could get you into serious trouble, and we need to protect you from that and provide you a lawyer to handle those things for you, is quite different than you saying, I don't want to engage in medical care. Because what we're doing is we're preventing you from opting into a situation that by its very nature can be very harmful to you.
Which is different than, should you be allowed to manage your own finances, right? There's sort of different domains of capacity.
Exactly. And I think with psychiatry in particular, we have this vulnerability to over-medicalize things. And I don't know if this, the cynic in me says, well, this is the narcissism of healthcare and psychiatry particularly, that we've kind of absorbed safety as a medical illness and decision-making as a medical sort of process, as opposed to a legal and philosophical process, in which case I think we should try to step out of it and say, there's not really a benefit to us getting involved. But there is an argument for it. And I think the argument for it is based in this alternate definition, which might take us to a better model. And the alternate definition is, if you take a step back, what are we trying to do with capacity assessments? It's a question I really struggled with. And sometimes people say, well, you want to make them safe decisions or wise decisions or medically prudent. Those are some of the sort of quick answers you get. But that's not really what we're trying to do.
Right. That flies in the face of what you're trying to do in a way. Directly, actually, exactly. Right? Yeah.
Yeah. That we're allowed to make unwise medical decisions. We're allowed to make unsafe decisions. Like, that's not what we're trying to impose. So what is it that we're trying to do with the capacity evaluation? Like, what are we afraid of? And I think when you think about it, it's usually about making value incongruent decisions. So things that we know that you wouldn't want to do due to an impairment, which is reversible.
Yeah, this is a whole different way of thinking about capacity, and I totally agree, right?
Right? Which is to say, okay, and we can think of like the prototypes, like if you're intoxicated and all of a sudden you decide you're going to, you do something very unlike yourself. Then we could say, okay, well, that doesn't align with the person I know, so it sounds like it's value incongruent. We don't see that this is in a sort of like impaired free state. So like, obviously there's a sort of impairment present that could explain why your values are incongruent. That'd be the intoxicant. And then it's reversible, meaning like if we could suspend your decision-making for a moment, the hope is we could get you back to a place where you can be back in the driver's seat. If we just pause for a moment, I think that's sort of the prototype of what capacity is designed to defend against.
And I could see that in the case of mania. I could see that in the case of delirium. I think where it gets really complicated is thinking about it in the case of major neurocognitive disorders, which I think are where this often comes up. I want to make a few comments on some of the things you just said. So one, totally agree with you that we should avoid over medicalization of humanity. And I think psychiatry is really at risk of doing that. We start each season with Alan Francis as our guest, and he wrote a book called Saving Normal. So you're definitely in good company here in terms of trying to make sure that we stay out of the way as much as involving ourselves in people's lives. Two, your comments on making capacity a highly cognitive task where we're testing things like understanding, appreciation, and reasoning, those things are informed by culture, socioeconomics, life experiences, education level. And so I think that is where social justice comes into play. And it's, are we just wielding our paternalism and our medical power against people who are not in a position to meet this test that we have specifically designed, so that then we can do whatever we want to do to these people? And I think the third piece is, as a physician, as an attending now for about 18 months, I can see where it's so easy for these comic book characters who were violating capacity or doing an exam under ether to start to think, well, I do know better than everybody else. Shit, I have 4 years of medical school. I have 4 years of residency. Every time I tell a joke to my team in the hospital, everybody laughs. I'm a funny guy. I'm a smart guy. And so I think if you're not really careful, you can start to, with the road to hell is paved with good intentions, right? If you're not really careful, you can start to influence people's choices and behavior. So you have some kind of other ideas about maybe where the Applebaum-Grisso criteria is not the best model for addressing capacity in certain cases. How do you think about the standard of care here? Because I feel like, based on the most recent APA guidelines, those rely pretty heavily on the Applebaum-Grisso criteria. So I feel confident in saying the Applebaum-Grisso criteria meets the standard of care. Do you think of these other models as alternative ways that do meet the standard of care? Do you think of these other models as kind of emerging measures and models that we should think about and maybe try to make more robust? Are they ready for prime time? What do you think?
Yeah, no, it's such a great question, particularly as we think about what are the next steps. And you're absolutely right. Applebaum and Grisso are really cemented as the standard of care. And there really isn't many models that come to mind that compete with this as an alternative. And that's where, Dr. Appell, Jacob, who I'm sure you saw speak at the ACLP conference and who's partnered with me on a lot of the sort of publishing that we're doing around capacity, has proposed an alternative. And I think we've really, over the last couple of years, tried to build the literature base so that there is a viable alternative. And he talked about sort of the respectable minority, and that while there is a dominant sort of standard of care, the law does see minority opinions that are respectable and held by a decent amount of people to be viable alternatives. Otherwise, if you only have a standard of care, then there's really no incentive for innovation or evolution in care. And so you tend to sort of devolve into one approach that may never be challenged.
I've just never heard this before. Respectable minority is a term that relates to another version, like people can meet the standard of care by being a respectable minority. We don't say just because you're not doing what everybody else does. There's a specific legal terminology for this. It's a well-respected. That's news to me. I think super interesting. Thank you. Sorry to interrupt. Go ahead.
No, yeah, and I think it was a wonderful sort of point that Jacob Appell, who just happens to also have a law degree, to bring up in terms of tort and medical liability, that there is this concept that protects physicians who are attempting to propose alternatives or choose alternatives that may not be the quote unquote standard of care, but still be followed by a respectable minority. And so that's where we've worked really hard to kind of build the literature base on which we can start to propose these alternatives. And so Dr. Appell has really pushed forward a wonderful model that focuses more on values. If we take that definition I talked about earlier, which is, value incongruent decisions caused by an impairment that we could reverse, then, the Applebaum model, which focuses on understanding, appreciation, communication, and reasoning, really doesn't account for values at all. And so then how do we know we're upholding the free will of the person if we don't understand what is important to them? What are their values? Because then what all that model really does is account for one's ability to sort of retroactively justify through a very cognitive approach their decision making. I said this joke at the talk, and I free will for me is not the ability to justify your choice. A lot of times we don't sit there and discuss the risk benefits with ourselves about certain decisions. There's usually a certain desire or value and maybe an expected outcome, and then the impulse to complete that decision. And I use the example of buying Bitcoin, which, if you assess me on a cognitive assessment, with understanding, appreciation, risk, I would fail miserably. Yet nobody infringes on my ability to do that because we're not necessarily in that ecosystem where that power asymmetry is leveraged for I would say a like biomedical logic, and we see that in healthcare that we privilege the biologic explanation for everything, the biologic understanding and reasoning. And when patients don't come to us with that, when they come with their sort of indigenous and instinctive knowledge and expertise, we often dismiss that as, not understanding or not appreciating. And then that's where the harm comes from because we strip people of their ability to make decisions based off of a model that we have designed that favors our reasoning and logic as opposed to centering one in the patient. And so that's where his sort of alternative, which is values-based, to say, first, let's assess, is there a discordance between what this patient wants and what we know their values to be, right? Well, actually, let's take a step back before that. We have to assess their values, right? So we have to be aware of their values. And this is going to come kind of naturally in one working with the patient. When you get to spend some time with them, you get a sense of like what makes them tick, what do they like, what do they avoid? And that's part of the relationship that you should have as a physician with your patients to understand what's important to them and sort of from that extrapolate some idea of their values. Then try to see, is the decision that they're making right now, does that match with their values? And there's a lot of economic literature out there that says we make value incongruent decisions all the time, right? So it's not that the incongruence in and of itself is a sign of pathology, but that might warrant our curiosity rather than refusal or unwillingness to participate in a biological explanation. We should really kind of measure one's capacity against themselves through the idea of their values. What is this person's values? And if this decision seems inconsistent with their values, that should warrant our kind of concern. So, for example, if we have the grandma who's like been the most adherent patient her entire life, and then all of a sudden, the doctor is saying, hey, look, you have a very serious condition, and we propose this, and all of a sudden she's like, I'm absolutely not doing that. I'm going with my alkaline diet. Then you might say, wait, this doesn't sound like Miss Smith. Miss Smith takes pride in going to all her appointments, and she takes copious amounts of notes and loves to, sort of adhere to a medical framework of care.
And maybe we do let Miss Smith make that material, Grandma Smith make that decision, but you're just saying it should pique our curiosity. You're not saying that's the test. You're saying that is the reason to do the test.
That's the reason to. Then you kind of say, okay, well, I'm curious now, right, that we seem to have a sort of disconnect with her own values as we know it. Let's see if there's a reason that could explain this, right? That either is quite rational, like maybe she changed her mind, fine. Or is there some impairment that we know that could influence someone's abilities to have value consistent choices? And that's where you could say, okay, well, I know if she's delirious, that's a good reason to suspect that maybe, or explain why her values are changed. Or if she's intoxicated, or if she's, experiencing another sort of cognitive or mental health issue that might influence that. And then from there, you might think about, okay, now, is there a solution to this that we could resolve, that we could help restore her ability to make decisions that are value consistent, And so what we're doing here, rather than focusing on the comprehension of facts and the appreciation of those facts from a model that we privilege, we're really starting to look at, okay, what's important to this patient? Is that translating in the decision making that they're making right now? And if it's not, can we come up with an explanation or solution that addresses that? And with the intention, again, to try to firmly center the patient in their decision making, not to remove them from that.
It really is so radical. And if you're listening to this podcast, and you don't regularly work on a CL psychiatry service, it might be hard for you to appreciate just how radical what Dr. Mirza is proposing is. I'll also say that I appreciate you toning down the radicalism when talking about the reasons that we do leverage our power dynamic in the hospital. You mentioned that we do that for biomedical reasons, and I hope that usually that's the case. But I think there are probably medical legal reasons that are not biomedical in nature that we leverage that power dynamic. I think we have to admit that there are economic reasons that some people would leverage that power dynamic, just to put it mildly. But I appreciate you trying to give clinicians the benefit of the doubt.
Yeah, well, we could turn
Go
up
ahead.
the volume.
Yeah, yeah.
It's funny you say that because, I'm working on a paper right now with a colleague of mine about capacity as a colonial act and sort of the metaphor of colonialism, where you see that there's the physician that's the colonizer, privileged, feels that they have a superior morality and knowledge, and that they want to subjugate the patient, who's the sort of indigenous, and we colonize their body and civilize them through a process of capacity, right? That, oh, it's not that you have a different value or you privilege a different perspective. It's that you lack civility, or in this case, capacity. And so we have to, for your own benefit, right, civilize you. And that means take away your refusal or claim your consent and do what's best for you from our perspective. And so in many ways, it really sort of echoes that colonial mindset. And in that sense, there's a lot of literature that sort of talks about how there is this sort of imperialist ancestry to the way medicine is practiced, particularly in the sort of like the power asymmetry that you see between physicians and patients. And so my perspective is really grounded in, I think, like an anti-colonial lens to say, we are here as friends, companions,
Servants.
as servants of our patients. And in that sense, we have to take a sort of humble approach and recognize that the patient's got a lived expertise in their body, right? There's nobody who understands the patient's, perspective better than they do. And so when I meet patients, I say, look, you're the expert of your body. I'm never going to have more knowledge about your body than you do. I can only bring sort of this textbook knowledge as a tool that you can use with your own expertise to make decisions. And so my job is not to tell you the right or wrong decision. My job is to sort of really create that disclosure, which is to say, here's the information that I can bring to you to serve you in what it is that you want to do in this moment. And that might not be what I want for you. And I have to accept that that's not my job.
I don't think it's a stretch at all. I think that the argument that you laid out, to me, it's common sense, and I think it happens all too often. I think we would agree that at its best, the Applebaum-Grisso criteria, at least the intention was that it would be a way to serve your patient and to work in this model. But we've both seen cases where it has not been used in that way, and I think that's probably what makes you so passionate about it. So when we're talking about this values-based assessment that your friend and colleague, Dr. Appell, has sort of introduced as an alternative model, or sitting down with a patient, getting to know the patient, getting to know the patient's values, I'll point out that that's extra tough on a consultation liaison setting where you don't know the patient longitudinally. And so you may have to take some time out of your day. You definitely need to sit down and get below eye level of the patient and get to know the patient. You're seeing what the reason is for this decision that seems to be against the patient's values. You're seeing if you can find a solution, if you can find a way to resolve it without asking these cognitive questions. We are going to take a quick break, and when we come back, we're going to get into the nitty and gritty of how we would think about doing this at the bedside with the patient, and then we will talk through the free will example that you put forward in your graphic novel. Welcome to May, and did you know May 12th is Mental Health Provider Day, a day to think about all the things that we do as mental health providers, maybe to receive some external recognition. I know for me as a mental health provider, one thing that I often talk about is just how cognitively demanding it is, how it's difficult to balance work, balance home as a mental health provider. And that's why I want to tell you about Simple Practice. Simple Practice is an all-in-one EHR that is HIPAA compliant, high trust certified, and built specifically for therapists. It brings scheduling, billing, insurance, and client communication all into one place, so you're not juggling multiple systems just to run your practice. Simple Practice has a lot of amazing features. It has an AI note writing tool. It has an easy way to send lab slips out for your patients to get their labs done. And if you're just starting out or growing your practice, there's also a credentialing service that takes the headache out of insurance enrollment, which honestly can be a huge lift. If you've been on the fence about joining Simple Practice, now is the perfect time. Simple Practice is celebrating Mental Health Provider Day with an exclusive offer to help you grow your business, up to 70% off for 1 year. This offer is only good May 11th through the 15th, and it is the best deal Simple Practice has ever offered. 70% off for 1 year. Go to simplepractice.com. That's simplepractice.com. Spring is coming to a close. We're moving into summer. The sun is out, which means lots of fun, lots of social gatherings, lots of outdoor time. Sometimes it can mean a little bit less time at home, which means your time at home is now super valuable. So you need to be both cozy and at times productive. And that's why I want to tell you about the brushed bamboo jogger set from Cozy Earth. It's so comfortable, it's so sturdy, it's obsessively engineered, and it's not just fast fashion for the home, it's something that you would reach for years from now. Same with their new clogs. Their clogs are comfy, almost like slippers, but sturdy, so that you can wear them outside, so that they support your feet as you're maximizing that at-home time this summer. Cozy Earth stands by their products with a 100-night sleep trial, so you can buy the product knowing confidently that if you don't like it, you can just send it right back. But I have lots of Cozy Earth stuff by now, and I promise you that you will like it. And they have a 10-year warranty, so you know it's something quality that's going to last you a long time, unlike a lot of their competitors on the market. This spring, give yourself the kind of comfort that lives with you all day, not just the moment you get home. Head to cozyearth.com and use my code BOOTCAMP for an exclusive 20% off. And if you see a post-purchase survey, be sure to tell Cozy Earth that you heard about them right here on Psychiatry Boot Camp. Cozy Earth, comfort lives here. Welcome back to the podcast. So let's get into one of the things that you said that really struck me at the San Antonio meeting, which was I had been conceptualizing capacity assessments as something that needs to happen in order to do an intervention or consider doing an intervention. I have not been thinking about capacity assessments themselves as an intervention, right? But you seem to think that the capacity assessment itself is an intervention. Could you tell me about that?
Yeah, absolutely. This is based off of a paper that Jacob Appell and I put out, basically calling for capacity to be reconceptualized. And this came from some anecdotal changes that we were doing when approaching this, which is to see the capacity assessment itself as a clinical intervention. And this comes from the idea that capacity has harms when you introduce it into the care. And when you work with folks in CL, I mean, everybody nods their head because this is so intuitive, observing how capacity is used in care and how it can cause sabotage to the patient-physician relationship, how it can inflict coercive treatment on people. It can further traumatize folks who've, experienced a great deal of trauma in the healthcare system. So you start to see that it's not just like, hey, I'm coming to measure your height as a sort of like very benign or inert interaction. It really has consequences that could harm people, particularly around, their autonomy and just their sense of agency. There's a great deal of harm there. So if you start to observe that and you start to, believe that there isn't negative consequence of this, then you start to think, well, you got to be a little bit more judicious about the application of this. And that's where we started to say, it's no longer a capacity assessment because assessment seems very benign. I'm just going to assess your height and weight. But really, it's a challenge. And the challenge being, like a glucose challenge. It's like a provocative test. We are, testing your cognition via these questions that can be intrusive, that they can feel dismissive, invalidating. And so if you recognize that, you start to see this less as assessment, more as a challenge. And once you begin to incorporate that challenge sort of terminology, that semantic shift starts you to recognize, well, challenges might have some risk associated with them. And those risks are the ones we talk about.
Talking about this with you, I'm amazed how well I remember that talk in San Antonio. One of the things that you said was, because it was months ago at this point, your favorite consults, or maybe your least favorite consults, are the kidnap my patient consults. And these are a very common consult that we get of grandpa is refusing sniff placement. Do they have capacity to refuse sniff placement? Let's just use that as sort of our example, because I think it's such a common one. And if you're going to talk about kidnapping, the harms seem pretty obvious. But walk me through the harms of even asking that question and doing the capacity challenge.
No, absolutely. Usually by the time we get involved as CL psychiatrists, somebody might have already, who's read the Applebaum article or is at least familiar with it from their medical education, has probably already asked the patient, do you understand the risks of going home? Or do you understand? So that in and of itself, that sort of challenge to one's autonomy, followed up by a psychiatrist who sort of echoes those questions, can be very dismissive and validating, to say, why do I need to explain myself to you? Like, what authority do you have over me? Aside from the physical containment that you have of me via this environment, what authority do you have that allows you to question my expression of my choice? It's a free country, as people like to say. So that in and of itself can be very intrusive, that question, and making people defend themselves in terms of their choices, not just for the first time, but likely third or fourth time, because maybe a med student's asked these questions, a resident, maybe the attending, and in the sense of their concerns now calls psychiatry to come. So now you're the fourth, maybe fifth person asking these questions. It becomes very demeaning, dismissive, and intrusive. And so people can be very offended by the question itself. And also the idea that, who are you to ask me, right? And this comes from this idea of like, what is our relationship? What interpersonal currency do we have with people to ask these questions?
Usually none.
None, right? And then where do we derive the empiric authority to do this besides our own power that we've created in this environment? And it brings an interesting sort of thought that popped into my head about this when somebody called me from an outpatient office once and said, I have a patient here. I don't think they have capacity. What should I do? And then I thought about it. I'm like, well, what can you do from an outpatient? And then I said, well, wait a minute. If our construct dissolves over the boundary of inpatient, outpatient, then is this really about power or is this about something empiric? And then I realized this is really a flex of power that only exists within the confines of the boundaries of the hospital. Because once you get in the outpatient office, if somebody says something and you don't think they have capacity, there's nothing you can do about that. It's just a word that you sort of throw at them. But they're going to walk out their office. They're going to retain their power. It's when they're vulnerable and in the confines of our environments in which we control them, right? We put them in uniforms, we give them numbers, label them, that we can now tell them that, yes, I have the authority to interrogate your decision making. And that's where this whole thing becomes very dangerous and why we sort of see it as a intervention that has its risks and benefits. Like, a lot of people are like, well, no, we're just checking to see if they have capacity. It's not like you just check the abdominal cavity with an exploratory lab just to see what's going on in there. Like there's a risk to that. Even though you might be looking for something and you have some concern, you're not going to just open people up just to see. And therefore, I don't think that we should be going in and interrogating people's decision-making and choices just because we're concerned, right? There needs to be a sense of responsibility. And if we're going to rope back in the sort of comic book analogy, the Peter Parker's uncle Ben said, with great power comes great responsibility. And there's a great deal of power that we hold over people's lives in this environment. And so with that, we have to have an immense amount of responsibility. And so to sort of talk to the revolutionary who's really empathizing with this approach, the first thing you got to do is just reconceptualize how we talk about capacity, and that it's not an assessment, it's not a measurement, it is an intervention. Like the same way that you would do an exploratory lap. And if you do that, you're going to start to think about what are the risks in this and what are the benefits. And if there's no benefits, then I certainly shouldn't be doing this without really considering that. And I think that's what we ask as the sort of bare minimum.
I'm interested in that answer because when I heard you explain this, and I think even now, what I perceive, like I get that. It's intrusive, it's uncomfortable, it's offensive for sure to patients. It ruins their therapeutic alliance with you, with the hospital. Next time they need medical care, they might think, I'm not going to that hospital. That was terrible. They incarcerated me. And that would be fair. But when I think about the risks and benefits, I think about the risk of them being what? Restrained, sedated, kidnapped, taken somewhere they don't want to be. I think about the economic risks. Now they're settled with a bill from the hospital and they're settled with a bill from the SNF, and they didn't even want that in the first place, which is so fucked up. I think about the risks of ruining their relationships and them not being able to go home and see their pet and see their kids and quality of life. Are you thinking about all those as well? So this is a yes and.
Absolutely.
Then. Okay.
Absolutely.
And we should at least mention the benefits, though, right? The benefits being if they are making a value incongruent decision and or we have to do what the courts ask of us. But I guess what you're saying, too, is like we're misinterpreting what the courts are asking of us. They're not asking us to do the Applebaum-Grisso assessment on everybody.
Look, the reality is the courts are there to protect patients' rights against us. And I think that's an uncontroversial thing to think about because we don't see ourselves as perpetrators of any violence, but it is violence to deprive people of their ability to make choices for themselves, and you want care to be delivered to a person who's consenting. And if they're not, our focus shouldn't be about how can we sort of circumvent their refusal or opposition or hesitation, but really figure out what is it that they need from me to help make the best choice for themselves. And that might be a choice that I don't want them to make. And that's something we have to sit with, and so I think the focus has been lost in service of a model that's like, okay, we got to focus on comprehension because that's the standard of practice. And then there's liability associated with that. And obviously there's harm, which is a sort of broader principle. But I think those things cloud what really is the essence of what we're supposed to be doing, which is upholding consent. And consent's real focus is making sure it's voluntary, making sure we disclose. And then the third sort of stepsister is really the legal capacity issue, you know? And so you're right. The harms are incredible. So talking about that older gentleman, like, yeah, pulling him out of his environment, forcing him into a SOAR. And then we don't have any responsibility after that's done. I talk about like empiric authority. We do very paternalistic things with children or people we have relationships to because we have a sort of bidirectional relationship to them afterwards. Like if my children do something dangerous, I'm the one after the fact who's going to deal with those consequences as closely as they are for the duration of their life. I'm on the hook. As a doctor, I make that choice, and then 10 minutes later, that decision is now theirs to live with, but I made that choice. I'm not paying their rent. I'm not, feeding their goldfish that is no longer being fed. If you pull people out of their home environments, who's paying their rent? Do they get homeless after that because nobody was there to pay their bills because we plucked them out of their home and
kidnap them?
And we don't think about that. That's not anything that crosses our sort of equation of the decisions we make. We just look at it from a very narrow biologic lens. Like, is this the right thing for the pathology? Comes back to another thing that I wrestle with. Like, am I a disease technician in that moment? Is my primary responsibility to just sort of address the pathology that I see in that moment? Or is there something more holistic about what it means to be a doctor, which is to maybe relieve suffering, optimize health? And those things may not always be treating the specific pathology at that point, but recognizing somebody's home environment, the comfort of the people around them, or their own anxieties are a big part of what makes them healthy and well. And those should be just as important to me as treating the hyponatremia or, addressing the infection.
Couldn't agree more. Okay, so let's talk about kind of how the literature has evolved. If we're going to reconceptualize capacity beyond Applebaum-Grisso, I think you brought forward something, would I call it the free will model? Could you tell me about this?
Yeah, I'll jump into that first, but that is published not in any peer-reviewed journal. So it's based off a lot of peer-review articles, but it hasn't been peer-reviewed. So I want to qualify that.
This is kind of your idea of reconceptualizing capacity that you're putting forward.
Yeah, and that's sort of the next step. If you've accepted reconceptualization, you're like, that's good, but I want to go further. Then I think the next model is the free will model, which is something that I use to teach residents and students as a framework to help them with all the different variables and levers that often get pulled in capacity. Because it can be very daunting. A lot of people really struggle with it because there's so much legal and ethical intersection into this. So I came up with this mnemonic, free will, intentionally, because at its core, I think what we got to remember, this capacity is to support free will in the context of consent.
And at your core, you are an academician and you love acronyms. Admit it.
Yeah, exactly. You got to remember what they stand for, though. So, but in that, I've sort of outlined these headings, which kind of will guide your approach, which is first foundation. So a lot of medicine is practiced locally in terms of the laws that regulate it. Those are at the state level. So I think it's important to just familiarize yourself with the laws in your state, as well as nationally. You got to get a sense of the background, because a lot of anxiety around capacity is just, I don't understand the law. And so without going into it really quickly, I'll just say the law very firmly stands in support of patients making their own decision. They are not necessarily as concerned with what's medically the most right thing to do. It's more about making sure we protect patients. And so all the laws that you will encounter in this search are going to show you that that's what the law sees. So once you've established that, you can feel a little bit more comfortable going into the next part, which is interrogating the reason. So why is the capacity being challenged in this moment? And it might be that the patient is refusing, or the patient is, really readily accepting, whatever it might be, to kind of get that clear, because that'll help guide you moving down the line in terms of what to expect. Then you want to understand who all is involved. So the E is everyone. Identify all the key players. So if this is like a game of chess, it helps to know what each piece can do so that you can anticipate the move. So if you know the team really just wants the capacity consult to sort of bless the signing out of AMA, or there's a daughter involved who's really anxious, or there's a legal and risk that's involved, then you start to kind of see the board in terms of who's playing what position, and you can anticipate what everybody's interests are, which leads into the next one, which is, what is the expectation? What does the patient expect? What does the family member expect? What does the team expect? And if they all align, sometimes, the patient wants to sign out AMA, the team wants them out, and then the family wants them out. So I'm like, if everybody wants the same thing,
Why am I
what's the
seeing
point
the
of it?
patient? Yeah.
Yeah. Right. And then you realize it's really more about some liability anxiety or something else, and not necessarily, hey, if everybody's aligned, then like there's no point in bringing this up. So kind of getting the foundations, understanding the reason for the consult or the question, and identifying everyone, and then understanding the expectations. This can all be done on the phone. So I like to do phone work in CL, which is really work the team. So before even seeing the patient, you can get all this information, and that can help you sort of find your way out of the capacity question to say, okay, wait, this is not a need for us to do this right now. If everybody agrees, like, just let the patient go. It's not a big deal. So that's the free part. Then you go through that, and let's say you still feel, or the team still feels, that there's a need for you to actually do some more work with the capacity. Then you can go into the will part, which is really when you approach the patient, what's the stance you take? And so the first one is, what does the patient want? So rather than coming in hot saying, do you understand the risk benefits, which is usually how much of us approach this, because we want to jump right into the Applebaum criteria, I think the approach should just be, hey, tell me what you want. I just want to understand what you want, because I'm hearing things from everybody else. What is it that you want? And this gives them an opportunity to articulate their perspective, and it gives them a chance to feel validated and heard, and for you to build some currency with that person. So I'm not coming with any agenda other than understanding what is it that you want. And then going into the investigation. So once I've got a sense of like, what is it that you want, the I would be kind of gently investigating. And that's with a curious lens, like, what is it that the team's worried about? Why do they not want to agree with, what you're saying? What is their concerns? And I talk about sort of the DJ Khaled method of this approach, which is kind of externalizing the bad object and saying, like, there's a they, them, he out there.
They don't want you to win.
They don't want you to win, right? They don't want you to sign out AMA. They don't want you to refuse or whatever.
I'm allying myself now with the patient against this they.
Exactly, right? So we're creating, a relationship, a partnership in understanding what is it that other people don't get about what you're saying. Because it seems at its face value very reasonable to me. And that, again, sort of an attempt to kind of repair any invalidation or dismissive feelings that the patient might harbor when you approach as a psychiatrist. Because it's going to be loaded. As a psychiatrist, people are going to be like, oh, great, they think I'm crazy. So you kind of approach it as, hey, I'm here as a concerned person that wants to understand you and wants to understand why other people can't understand you. And that helps you investigate their sense of what was communicated to them, why people might be worried about what they're choosing. And so in a sort of backwards way, you're doing the Applebaum assessment. You're doing the cognition. Like, what are the risks? Why do they think this is so risky?
Eventually, you are still doing that assessment. You're just taking a lot more context.
Yeah, exactly. And so you're still taking sort of the standard of care approach. You're still getting that, but you're just coming at it from like an oblique angle so that it doesn't feel as directly challenging or offensive as maybe some of the traditional questions are. And then you start to listen, and that should be happening all the time, but you're really listening because, in my opinion, capacity is rarely about one's cognitive abilities. It's usually about breakdown of some type of communication. So you're listening to find out, what is it that this person is really communicating? Are they fearful? Do they just need more time? Are they hangry? I can't tell you how many times I've been called for a patient that's refusing, a surgical procedure. And, they're told the day before, you're going to be NPO tonight, and then we're going to take you in for the morning. And the, morning passes, and it's 2 p.m, and that patient's now hungry, tired, and doesn't realize that, their case got bumped, etc. And then as an act of sort of frustration, they say, no. Yeah, And so in that sense, it's not about understanding appreciation. It's just hearing that, hey, this person's tired, they're hungry, and we should just cancel the procedure, reschedule, make sure they get in bright and early in the morning, and then, that's salt. And so that leads into the sort of next part, which is rather than just kind of pursuing capacity to say, okay, I've listened and I can foresee a logical solution to this, which doesn't involve decentering that person from the decision making, but rather saying, okay, you're hungry, or would it be more helpful or reassuring if we called your primary care doctor and asked them what they think about this? Like, do you have people in your life to help you make these types of decisions? Would it be reassuring to not hear from me, but maybe from your wife or your doctor? Or can I print you some stuff and let you read it? And then can we talk about this later today?
Can we delay this procedure, treat the underlying condition, and then maybe go forward with it, or not go, or at least then you can make the decision?
Yeah. Or if this doesn't happen, and let's say your way doesn't work, would you consider it after that? Just trying to compromise is really what you're trying to do, and that sort of listening for logical solutions. And that gets you to a place where you don't have to go full force and deprive that person of their decision making, but recognize that most of the time you can solve these issues. People come to care or come to the hospital because they're feeling unwell and they're seeking some type of relief from that. And I would think most of us come to work to provide relief. So if we both enter this equation with the same perspective, then something happened, most likely in the communication, where those two things don't align. And we just need to focus on troubleshooting that rather than saying, okay, the fastest way to, treatment is to attack your ability to make this decision through this model, which is excessively cognitive. And then it deprivileges people who have lower education, who have lower socioeconomic status. If you look at the Barstow study, which kind of laid out a table of all the different factors that are predictive of risk factors of losing capacity, a lot of them were just, signs of like power asymmetry, people who had less than a high school education, people who had a uncomfortable prior experience with the healthcare system, people who didn't speak English. Like, how do those map to a cognitive model of capacity, if not just being proxies for having socioeconomic vulnerabilities? And so that's where I really struggle with the model, the Applebaum model.
So that is our free will approach. You can listen back through that and you'll find each of those letters in that acronym. If you want more on it, buy the graphic novel linked in the episode notes. I've never read one of these before. And I was like, I showed my wife, I was like, this is so cool. So that's where you'll find more about the free will. It will all make sense. I'll also add that decisional capacity is decision specific. And when you get to that final L, that logical solution, you're also then determining, okay, now that we've had this conversation, now that we've phoned a friend, now that I've gotten to know you a little bit, it sounds like you're telling me that you think this is your decision. This logical solution is what you want to do. And in that case, probably we're all going to be able to agree with it. That's the decision that you're making. You do have the capacity to make that decision. And we can move on with our lives without getting trapped in this binary or getting trapped in this model where it's me versus you or all about medical legal issues, etc.
Exactly.
Okay, so the Jacob Appell values-based assessment, if I wanted to go into work tomorrow and do this with a patient, could you tell me how?
Yeah, absolutely. I think it starts with really beginning to understand and learn about the patient. And that, I don't want that to feel like an extra chore, right? That should be something that we are doing in the process of caring for somebody. Like, care shouldn't be so detached from the human being that we don't understand anything about them. And I think, sadly, the pressures of healthcare have made that feel more distant from what we are supposed to be doing. Though that's not the case or the experience for patients. Patients come looking for comfort, and that's not necessarily always the most technical surgery. It's the expression of care. And so I think you have to really begin by kind of returning to the core values of what it means to be a doctor, which is to provide that care, to be understanding, to learn about that patient. In that process, you're going to get a sense of like, what are their values? Are these people who prioritize immediate gratification? And we know a lot of those in the hospital, right? Who just, they live 2 minutes at a time and nothing matters after that, and those might be the folks that are perceived to be most disruptive because in that moment, it's just right now. There might be people who are really thoughtful and cautious, and so they don't like to do things without extensive explanation, etc. And that'll map to what their values are. And so once you have sort of a little bit of an understanding or construct of their values, then you can start to see, is there some discordance between the values? Like, is there something that this person's doing with the preference they're expressing right now that doesn't match with what I perceive to be their values. And remember, this is our perception too. So we have to recognize that this may not always be accurate. The only person who truly understands their values is going to be the patient. And so it's, as much as we like to think that we can get a sense of that, it's going to be hard to really truly know that. But at some level, we're going to make an effort to sort of understand that and sort of make sure that those things align. And if they don't align, can I come up with a plausible explanation for that so that I don't have to attack or challenge this person's capacity? And it might be, hey, that person doesn't think this is, in line with their values for a specific reason, or maybe their values have evolved in the course of this time. So there might be a reason that explains it. If there isn't a reason that's acceptable, but it's a reason that we think that we can treat, like say delirium or a manic episode or something where there's a intervention that could reasonably restore that person to a position of making more value congruent decisions, then you want to focus on that as opposed to depriving them of their ability to figure out, okay, if this is, let's say an example, intoxication, maybe let's delay the decision a little bit until they're less intoxicated and then ask them again. If it's like mania, right? Then that's something maybe we can offer treatment in terms of a mood stabilizer to try to help get them back into a position where they can make it. All with the focus of really kind of, as much as possible, empowering the patient to make decisions that are consistent with their perspective or value. And there's going to be times where that's just not possible, right? And that's where you kind of have to break the glass and say, okay, I have assessed this against your values. I've tried to meaningfully intervene in a way to restore that capacity. And if I'm unable to do so, now I have to really kind of decide or make the decision about whether we're going to intrude on one's autonomy. And I think that's the way we should look at it. It's like really breaking the glass, to say, okay, this is a situation. We got to pull the fire alarm out, right?
It's not always given that reverence.
And that I think gives it that sort of that reverence, that sort of respect for how intrusive this is. And that's where you still hold on to the sort of idea of capacity. And then there's this space now if you've accepted all these and you're like, hey, these are great, it's intuitive, and you really want to push yourself, I've become more and more disillusioned with capacity entirely, to a space where I think Bogle is, they put out a real interesting ethics paper a couple of years ago about just ditching capacity entirely. And more and more, I'm leaning towards that perspective. We can get into that if there's time and space for that.
Let me point out one thing you said about the values-based assessment. So in this case, you are looking at whether or not the decision that the patient is making aligns with their values. And one thing that occurs to me is, in a way, you're reframing the sliding scale. So the traditional sliding scale in capacity assessments is basically, is this a bad decision? Meaning, do the risks pretty clearly outweigh the benefits? And if so, then we would slide our scale over and say you need a very firm grasp of the Applebaum-Grisso criteria for us to allow you to make this bad decision. Or is it something where there's a lot of benefits and very low risks? And so even if you're not able to really explain your thought process that well, it's pretty clearly a good decision, and so you don't need a very strong command of the Applebaum-Grisso criteria, right? That's a traditional sliding scale. But in this case, the sliding scale is, how far off from your values is this decision? Is this decision really far off from your values? And based on what I know about you and what your family has told me about you, this is a wild thing for you to be doing? If so, then we might need to really interrogate or maybe investigate, in your words, that thought process, those Applebaum-Grisso criteria, to make sure that we're serving you the best we can. If this is, it doesn't even matter if it's a good or bad decision. If this is something that is really in line with your longitudinal values and who you are as a person, then I might not need to investigate the Applebaum-Grisso criteria so much, because this is par for the course for you. I think that's just fascinating.
Yeah, no, absolutely. And I think this is where we kind of like uncouple the idea of safety from capacity, because it's like a lot of things in psychiatry, unfortunately, we've medicalized good outcomes and bad outcomes. And there's a good paper by Robert Persk on dignity of risk, which I think I introduced at the talk. And the concept was, he worked extensively with the intellectually disabled. And he came to the conclusion that, there is this sort of intuitive desire to protect people, and we consider that sort of beneficence, do no harm, as our sort of fundamental duty. But in that protection, you can smother people by removing all risk in their life. And so there is a dignity in allowing people to engage in some degree of risk. And in a community, particularly the intellectually disabled, you can imagine how there is that extreme paternalistic push to deprive any risk. And that, he talked about it maybe from a philosophical perspective, but it's interesting to think that we're defined not by sort of the culmination of our good decisions, but really oftentimes the culminations of the painful and difficult decisions that we made that define who we are. So if you eliminate and sterilize all the risk that anybody could ever encounter in their life, you really deprive them of their identity and you erase who they are. And I think that, particularly around capacity, there's this push to say, okay, let's make sure that we don't allow people to make incapacitated decisions. But what is a capacitated decision? I mean, if you catch me hungry enough, sometimes I will make a decision that's not consistent with a decision I would have made 2 hours before. Do we intrude on that? Like, at what level do we decide this degree of
So
coercion or influence, right? Shame is a huge motivator in decision making. And I'm sure we've all made decisions that we weren't proud of because we were afraid of something or we're embarrassed or shameful. And are those capacitated decisions? And coming back to that sort of philosophical, what's a legal capacity where I have the authority to make decisions versus what's truly a free will decision? And I would argue there is no truly free will because we're bombarded by influences all day. Some of them we think are appropriate, like, hunger, poverty. Let's say you make a decision because of poverty. Is that a capacitated decision, or are you incapacitated through the pressures of not being able to afford things? We tolerate those things, even if they might have dramatic impacts for your life. But we say that's outside our domain. But if we have a laboratory error or value, that's abnormal, or if we have a pathology, then all of a sudden we see disability as incapacity. And then the disability rights people will say, by virtue of just having a diagnosis of schizophrenia or bipolar disorder, we're already stigmatized so much. And then you insert this sort of cognitive model that deprivileges our decision-making in this process and prioritizes people who may have high cognitive reserves and ability to sort of retroactively engineer a explanation for their decisions, as opposed to somebody who might lack a high school education or may not be so sophisticated in sort of the medical, biological knowledge that we wield so sort of disproportionately in the healthcare system. So, thinking about it from that perspective, you might say, hey, this is just more danger than harm. And to emphasize this point, I would say this. I think Stanford put out a study that said, poverty is in the top, 5 or 4 causes of death, morbidity and mortality in the United States. And I bet you if you looked at incapacity doesn't even come in the top 20 reasons of, morbidity and mortality. And so why are we putting so much disproportionate focus on this idea of capacity when there's many other things that we could try to leverage our collective efforts towards to treat? And I think it comes back to this sort of colonial understanding, which is intentionally or unintentionally, we have consolidated this sort of hegemony in medicine. And when there's a challenge to that through refusal or somebody picking a choice that we don't prioritize, then we leverage the full weight of our power to coerce that decision. And that only happens in settings where we can do it. Because the minute you step outside a hospital, I cannot do that anymore. Even though that might be equally or if not more incapacitated or, vice versa, it's something that we can only do in the ecosystem that we control. And so that, for me, really destroys the validity of this construct. That it's just, in many ways, I'd say, a sort of illusion of the power that we wield. And that really what we should be focusing on is the part of consent, which is to make sure it's voluntary, to make sure that it's with disclosure and it's designed to protect the patient against the conscious or unconscious influence of the healthcare system. And that, I think, is going to be more powerful for us moving forward. And we're working right now on a study because I think the assumption is that incapacity leads to dangerous situations. I don't think anybody's ever proven that, in the sense that when you look at people who are capacitated versus incapacitated, do the outcomes actually change? Do we have mortality or 6-month morbidity and mortality that prove that this process is really designed to protect patients? Or is this just an invention of our own sort of privileging of the biological model. And we're working on a study right now to look at that, to see, do incapacitated patients versus incapacitated patients have differing outcomes? We don't. It's an assumption.
Their life is going to look a lot different if we kidnap them and send them to a nursing home versus allow them to go home. Also, though, obviously the primary team in a lot of these cases has really strong considerations about them being able to be mobile at home, them being able to perform their ADLs, et cetera. So you would think that being somewhere where you could be helped with those things, I feel like common sense would indicate that you would have better outcomes in terms of morbidity and mortality. But I appreciate your point that we really don't know. And also, if you send someone somewhere that they don't want to be, it's more chaos theory. We don't know all the variables associated with that. And that's probably is definitely an interesting area for research.
Absolutely. And to speak to that point, like we will remove people from their environments for this idea of safety, that they can't function in the home, there's falls, etc. But when people come to us with clear evidence of things that are impacting their quote unquote safety, right? Like homeless. We're like, wash my hands of that. That's outside my domain. There's nothing I can do about that. And so then what gives us the authority to decide that they're so unsafe at their home that we must intervene? But if they come to us and say, hey, I'm homeless, I don't have food, and we see those people who are malingering or etc., we treat them with such, disdain. When they're very obviously presenting with the reason that they're suffering or that they're, struggling. And so for me, there's a sort of great hypocrisy, not in how we individually see that, but as a system, how we see those things. We see economic and socio-political things as just outside our domain that we just don't want to touch because it's not really healthcare. But then things that we can influence and wield power on, then we do so in some ways very aggressively, in a way that's inconsistent. And maybe the sort of social justice warrior version of me, or maybe the sort of anti-colonial version of me, will say that we have a great deal of power in society, and that if we're not leveraging it and wielding it to punch up and to protect our patients, then we're really just contributing to the potential harms. And that's where I take a great deal of inspiration for moving past the current model, which served us well when it came out, but no longer serves us in the same degree.
Dr. Omar Mirza, thank you for coming on Psychiatry Boot Camp. Thank you for helping us to expand our minds a little bit. Thank you for making us uncomfortable so that we can grow. And more than anything, I think your patients are honored to have you. You're a real advocate. You're really working hard, including volunteering for this 90-minute recording, just to make the world a better place for them, a more just place for them, a more respectful place for them. And I really appreciate you spending the time with me today.
Thank you. And big fan of the podcast. When I saw the email, I wasn't able to geek out as much as I'd love to, but I was thrilled. And so I'm very honored and grateful to be here talking to you and being amongst some of the great speakers that I've learned so much from.
Thank you so much for listening to this episode of Psychiatry Boot Camp. If you're enjoying the show, I would love to know what you think. You can connect with us on TikTok or Instagram at PsychBootCamp, or you can email me, Mark, at psychiatrybootcamp.com. Visit psychiatrybootcamp.com to sign up for our newsletter, and you can connect with the rest of the Human Content Podcast family on Instagram and TikTok at Human Content Pods. Thank you for everyone who left a review on Apple Podcast or Audible. Also, you can leave reviews on Audible, or a rating on Spotify. That's the best way to support the show. I really appreciate those. I read all of those. And I can't thank you enough for all of the ratings and reviews. You can find full videos of our podcast on YouTube at Psychiatry Boot Camp. Thanks again for listening. I'm your host, Mark Mullen. Our executive producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Mark Mullen. Season 4 is produced by Matthew Braddock. The outline for this episode was drafted by the great and wonderful Samir Jain, one of my medical students. Our editor and engineer is Jason Portizo, and our theme music was generously donated by Cave Radio. You can find Cave Radio on Spotify. Other music was by Omer Benzvi. To learn about our program disclaimer and ethics policy, our submission verification and licensing terms, and our HIPAA release terms, go to psychiatrybootcamp.com, where you can also reach out to us with any questions or concerns. Psychiatry Boot Camp is a human content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.